Good afternoon, Richard. Today I'm Dr. Nirmal from KIMS Hospital. I'm presenting a short case. KIMS Hospital, ma'am. I'm presenting a short case. This is a 40-year-old female patient named Rehana Begum residing in Hyderabad, not formally educated, informed and self, has come to the hospital with the complaints of bilateral lower limb swelling along with facial swelling since 2 weeks. Dating back my history to 2 years back, patient was a known hypertensive and was taking a single medication for hypertension. She remembers her medication was metoprolol. She had headache 2 years back with not associated nausea or vomiting, with no issue of any visual abnormalities.
Hypertension since 2 years.
Yes. And she has taken medication. She remembers it as metoprolol 25 mg. She has continued medication for 2 years. She doesn't remember any symptoms during these 2 years. There was no history of any pedal edema, oliguria, or frothing in urine. And since 2 weeks, past 2 weeks, she has reported symptoms of bilateral lower limb swelling along with facial puffiness. And there was no history of any joint pains, no oral ulcers, or no hair loss. There was no history of any rashes, skin rashes, or abdominal pain. And there was a history of breathlessness, NYHA grade 2. There was no history of any paradoxal nocturnal dyspnea, no chest pain, no orthopnea. And patient has no history of any fever, cough, and there was no other symptoms reported. And with these symptoms, patient went to an outside hospital where blood tests were done, and she remembers that creatinine level was around 2.9. And with these symptoms, patient has come to the NIMS hospital for further evaluation. And coming to past history, patient has no history of any recent hospitalizations or no. She just remembers that she takes medication for headache, occasional analgesics for headache, and there was no history of any diabetes, no history of any hypothyroid, no history of any CVA, no history of any recurrent UTI infections. And I would like to elaborate in the obstetric history. Patient has 6 children, and all were born by normal vaginal delivery, and all of them were term deliveries, and there was no history of any low birth weight, no history of any facial anomalies or any birth anomalies. And patient had told that patient remembers that she had hypertension during her pregnancy. Around 6 to 7 months, during 6 to 7 months of pregnancy, she remembers that she had hypertension after her third child, after her third pregnancy. And for this hypertension, she was given medication. 1 or 2 medications were given, and she remembers that there was no other abnormalities. There was no visual abnormalities, no history of any frothy urine, or no history of any headache or other symptoms, and there was no history of any joint pains or oral ulcers during this hypertensive episodes. And she remembers that she had continued hypertensive medication till her delivery, and they were stopped within 2 to 3 days of delivery. Like within 1 week, all the medication was stopped for hypertension. And she tells that after that 1 week she had stopped medication again for hypertension, and then she had history of 3 abortions, 3 consecutive abortions after her third child, and they were mostly in the first trimester during 1-2 months of gestation. And coming to her family history, there was no history of any CKD in the family, no history of any autoimmune disorder, and
When was her last pregnancy?
Around 10 years back, madam. Last
Any
child.
hypertension persisting since then?
No, madam. Only since 2 years she said she has hypertension.
Anyone checked the blood pressure at any point of time?
No, she doesn't. No, madam. She had not. Only when she had headache occasionally, then she went, and then she was told that she had hypertension. But during pregnancy, she was told that she had stopped all medication after delivery, within a week of delivery, and then she remembers that it was normal and she had not taken any medication after that. Her last delivery was 10 years back.
Significant history on examination?
Examination pedal edema, sir. Pitting pedal edema till the knee, and systemic examination was normal. There was no murmurs, no added sounds in the cardiovascular system. The respiratory per-abdomen system all were normal. There was no abdominal pain or tenderness.
Anything positive?
Only pedal edema was there, so no pallor, no BP 140/90, measured on both arms in sitting position.
On antihypertensive without any hypertension?
On antihypertensives, she is taking. Yes, sir. Yes, sir. there's no other positive findings in examination or history. A 40-year-old female with features suggestive of my syndromic diagnosis with rapidly progressive renal failure, with history of gestational hypertension and consecutive abortions, possibly immune complex mediated glomerular nephritis with probable APLA secondary to lupus nephritis.
Why should you say rapidly progressive renal failure?
She was
It
given
is
history of
developed edema
only
found to have creatinine of 2.8.
2 weeks history only she was given, madam, of pedal edema and.
Are you sure that she has normal kidney function prior to that?
No, madam. Could be a glomerular, she could be having glomerular disease prior to this also, but she had not reported any symptoms. Could be a nephronephritic syndrome, a glomerular disease also could be
2
there.
years hypertension
Yes, sir.
would be connected with all.
She could be having a glomerular disease prior to this presentation. So,
When you make the diagnosis of RPRF,
if the history is within.
what is the criteria objectivity comes when you make the diagnosis of RPRF?
History is within weeks, within days to weeks of presentation, then I would consider it as RPRF, sir.
Day 2 weeks?
Yes, sir.
So your timeline is very important in making any syndromic diagnosis in nephrology practice. So you should always remember in terms of the onset, in terms of the course of the disease, and in terms of the reversibility of these factors. Then only you will be able to make clinical diagnosis of the symptoms. So in RPRF, so what is the onset, what is the course, what is the reversibility factors? I'm just telling you this is all very
RPRF,
simple.
they could be divided into glomerular, tubular interstitial or vascular, sir. Tubular interstitial.
Not asking the causes. Behavior.
So when we talk about the RPRF, mostly we talk about
RPGN.
RPGN kind of presentation, and can be some differential diagnosis comes into picture because there might be some overlapping features. So what will be the onset? Acute, subacute, chronic.
Subacute presentation, sir.
So usually the onset is subacute. It happens in not within hours. It may happens in days to weeks kind of. Then what will be the course?
It will be initially oliguric phase of disease, sir, and then.
So most of the times these are not reversible phenomenon, RPGN, until unless you do some intervention.
Yes, yes, sir.
And usually happens within 3 months of the course. The course is usually limited to 3 months, and without intervention do not recover.
Yes.
RPGN. I do not think any RPGN recovers without intervention.
No.
Except some AIN can have a pseudo RPI, what we say, can have some reversibility with the drug-induced AIN. Otherwise it is not.
Yes.
So you should keep into the mind of making any syndromic diagnosis. So here a patient who have a hypertension of a long standing duration, you are making the differential diagnosis of syndromic diagnosis of RPI. Correct, no?
Because, but yes, sir, could be because she's saying since 2 weeks, but she has hypertension since 2 years. There could be a glomerular cause also, sir. No
The
differentials.
mistake you're making is that you don't know the baseline renal function
Yes.
and you're ignoring the 2 years hypertension. That's why it's on just the basis of swelling 2 weeks and creatinine now 2.9, so you're saying RP. That's where the mistake lies. You don't ignore those two things.
Hypertension is always important. No? This lady has a hypertension during pregnancy also.
Pregnancy also she had reported during.
So you have told us this was gestational hypertension.
Yes, sir, because it was more after 20 weeks of this. She is
After 20 weeks.
20 weeks, 6th or 7th month. She had this hypertension, sir. Not
So
the first.
gestational hypertension, what do you mean to convey us?
Hypertension more than 20 weeks of gestation, taken measured on 2 occasions, 2 weeks, within 2 weeks apart, with no signs or symptoms of end organ damage. Proteinuria will be less than 300 milligrams, and there are there was no symptoms of end organ damage like transaminitis or no CNS manifestations will be there.
So you are telling this was not the frank preeclampsia, it was only hypertension.
Yes, sir. She has no visual abnormalities, no headache, no CNS manifestations. She doesn't remember blood reports like urine analysis, proteinuria was how much quantification she doesn't remember, but
It's a long term.
chronic hypertensive, subsequently they'll
What's
be
the
having-
long term impact of gestational hypertension? Are you worried about gestational
Yes,
hypertension?
they're at risk of preeclampsia and
Preeclampsia is-
chronic hypertensive and
Huh? Hypertension coming and going in the third trimester of pregnancy without proteinuria, without any other organ dysfunction. Are you worried or not?
yes,
Why?
if there is a risk of preeclampsia during pregnancy.
आपने तो डिलीवरी कर दिया सब कुछ सबसाइड कर गया है ना.
There is a risk of renal parenchymal disease, like
Is it
chronic,
a renal parenchymal disease?
chronic hypertensive.
No, it is a pre-runner of primary hypertension. It's a pre-hypertensive state. Are you worried about the history of preeclampsia? Everything
ma'am.
subsides after delivery. Then?
Yes, ma'am. There is a risk of preeclampsia also.
Why? Do you want to keep them under yearly follow-up?
Like
What is their long-term impact of preeclampsia?
After the pregnancy is over, even after the baby normalizing, will you be concerned or not? That's what madam is asking.
we have
What are the
to.
potential long-term consequences of preeclampsia during pregnancy?
It could be linked to HELLP syndrome.
Hey, long-term, after 10 years.
Not immediate.
Just simple words. What happens to consequences of this preeclampsia, eclampsia, or gestational hypertension after delivery?
Chronic
Just consequences, tell us.
Cardiovascular mortality, complications.
Now this is the old disease. Now we have follow up for the 20 years, 30 years follow up of the preeclampsia patients data are available. So,
CKD.
so CKD, hypertension, how many patients, such patient develops hypertension, how
Cardiovascular disease.
cardiovascular mortality go up in this group of the patient. So you should know some of the studies which are there already in the publications, and so that is important. So just tell me, as a nephrologist or as a clinician, which end organ disease you would like to find out to define this is a preeclampsia? I am telling you, this one not simple gestational hypertension. It must be preeclampsia.
Renal.
So for renal involvement, what will you do?
Quantify urine protein creatinine ratio 24, urine protein should be more than 300 milligrams.
So this
Creatinine should be more than 1.1.
Unless someone has very meticulously seen this amenorrhea, you might not have the edema. Edema is no longer an essential criteria for making the diagnosis. Amenorrhea can be demonstrated. Amenorrhea of more than 150 milligram, 200 milligram can only be seen on investigations.
Yes.
So whether this has been investigated properly or not, that becomes the question. And even preeclampsia can be normal after delivery. Gestational hypertension can be normal after delivery. Which of these conditions is likely to put more sequelae after delivery? Preeclampsia or gestational hypertension or eclampsia kind of thing.
Which is more dangerous?
Preeclampsia and
Why?
It's for firstly the subsequent pregnancies there is a risk of, if there is a prior preeclampsia, there is a risk of LVH. And,
What is the pathogenesis of preeclampsia?
abnormal remodeling of spiral arteries, and there is defective trophoblast differentiation. So there is basically endothelial dysfunction causing placental ischemia.
Is it on the other way around? Placental ischemia causing endothelial dysfunction?
Yes, ma'am. Because of the abnormal remodeling of spiral arteries, there will be placental ischemia and
Placental ischemia leads to what?
endothelial dysfunction will be there.
How? What is the link between these two?
There is release of anti-angiogenic factors,
Mm.
so they can lead to endothelial dysfunction.
How these anti-angiogenic factors
SF21 and
exactly produces vascular endothelial dysfunction?
sure.
Important, very important.
As a nephrology, you should read about this preeclampsia in details, along with these consequences.
How do you classify preeclampsia?
Preeclampsia, preeclampsia superimposed on chronic hypertension, preeclampsia with severe
Classification of
weakness.
preeclampsia, not hypertensive disorders of pregnancy.
Yeah.
Classification.
According to the
Preeclampsia
timing
severe
at which it occurs.
Early versus late.
Early versus, yeah, exactly.
Reverse.
So what
When
is
will you
the-
say this is early preeclampsia?
It's 20 weeks, I don't understand.
Before 20 weeks?
Before 20 weeks, it is not preeclampsia.
The second, I'm not sure.
What's the importance of knowing this, early versus late?
And which is more common? Which accounts for the vast majority?
Early
of it?
preeclampsia.
No, it's the other one. So the early one is before 34 weeks. The other one is closer to term, so 37 weeks and later.
Yes.
And there sometimes can be in between, or some people classify it into three groups. Before 34 weeks, 34 to 37 weeks, and beyond 37 weeks.
Which is more dangerous?
So
37 weeks. Yeah.
more. The fact is, the one which occurs before 34 weeks lasts a longer time. You know, because it will last till the end of pregnancy. However,
Yes.
it accounts for only a small percentage of all preeclampsias. More than 3/4 of all preeclampsias are late.
Yes.
Right? So that distinction is very important. And the prediction also, the methods used to predict preeclampsia tells you much more about the early preeclampsia. You can predict the early one better. For the late preeclampsia, you don't have good ways of predicting, which is the big chunk of preeclampsia.
Do you have any evidence that preeclampsia is the response from the mother to remove the fetus, to discard the fetus from her? Is the rejection of the fetus for the side of the mother? Because there's a foreign antigen to the mother, isn't it?
Yes.
So do you have any evidence for that? Until C4D deposition seen only in preeclamptic pregnancies. Maybe the side of the mother acting as an antibody mediator rejection of the fetus. Sorry, we do not know.
Okay, you should go and read about this, hypertension,